guys, welcome back. The next topic I'm going to teach you is regarding narrow QRS complex tachycardia. Before I name the one that I'm going to be discussing, we'll have a look at the baseline electrical circuit of the heart. Well, at the moment I'm highlighting before you the normal conduction system in the heart, where the current will be starting from the SA node, move on to the AV node. You will notice that both sides of the AV node do not have equal refractory period. That's an important point, that AV node is slowly conducting. It has a AV nodal delay of 0.1 second, but I highlight the fact once again that both sides of the AV node do not conduct with the same speed. There's a variation with respect to the refractory periods, but finally this current will be able to hit the bundle of his. So there's going to be a septal activation contributing to the Q wave. The current will first go to the left fascicle, then to the right. So the refractory period of the right fascicle is also relatively higher, and now the current will be entering into the Purkinje system and then will be causing depolarization of the muscles, and now the ventricles will be able to fire. Now this is what happens in our heart on a regular basis, but I'll be showing a variation from this in a sense that in our patient, when the current is going from the SA node to the AV node, across one side of the AV node, the conduction will occur at the usual speed, but the other side is unfortunately at the moment having a high refractory period. So therefore you can see that at the moment I've shown conduction across only one side. This will definitely be able to activate the ventricles. So I have still shown a septal activation. The current will still be going into the two fascicles of bundle of his. So the onward currents towards Purkinje and ventricular depolarization will be normal. But now what I'm showing in the heart of this person is grossly abnormal. This does not happen in your and my heart, but is happening in this particular condition, the name of which I'm yet to speak before you, and this, guys, is shown as a re-entry current or re-entry phenomenon. Now the point that I would like to highlight here is that in your and my heart we always have a forward conduction, we always have an antegrade conduction, but in this case you definitely can notice that there is a retrograde conduction occurring across one side of the AV node, and this re-entry phenomenon is the troublemaker in this case. So let us now look at what this re-entry phenomenon will contribute to after few milliseconds. This is the AV node of the same patient. The current in red, the re-entry phenomenon or re-entry current, is now taking a 360-degree loop across the AV node. So at the moment, this current may also be called as circus movement. That is just to draw parallels with the circus trapeze artist, no? The artists on swing, they're completing a 360-degree swing here. And well, there are now two currents which are in competition with each other. One of the currents is shown in green, that is coming from the SA node, as it happens in you and me. The second is the current in red, the circus movement, and both of these are competing to first reach the bundle of his, because whosoever will win the race will be able to activate the bundle of his. Well, who's gonna win here? I'm gonna say two aspects. One, anatomically speaking, circus movement current, the one in red, is anatomically closer to bundle of his. Second, also the firing frequency will matter. So if the circus movement will fire at a rate anything more than 100, then it will be able to defeat the SA node, because SA node firing rate routine is 60 to 100. So what I'm generating here is a circus movement, a abnormal current in the heart of this person that was actually created after maybe taking a strong coffee or maybe I would say an energy drink like Red Bull, etc. But this current can now have the capability to activate the ventricles. So there will definitely be a faster activation of ventricles, resulting in a narrow QRS complex tachycardia. I repeat once again, this current is anatomically closer to bundle of phase. It fires at a higher frequency, so it's going to cause a faster activation of bundle of phase. So there's going to be a narrow QRS tachycardia. The remaining path of current is going to be fine. It will go across the left fascicle, it will go across the right fascicle, but the point is ventricles are now going to be firing relatively faster, and this current will now take this 360-degree loop. It will obviously travel across the contralateral side, cause an activation, and this entire circuit becomes the boss of the heart. The current keeps on rotating around the AV node. This abnormal current has become the boss of the heart, and therefore the topic name that I want to highlight right now. Normally I start with the topic and I tell you the pathogenesis. Here I deliberately first give you a line diagram to explain what's going on wrong in the heart of this person, and now the topic that I'm teaching you at the moment is called as AV nodal re-entrant tachycardia. You can now understand the meaning of the term relatively better. You can see that the re-entrant circuit is around the AV node, and therefore the treatment of choice for this condition would be ablation of this abnormal circuit. So we will talk about the treatment part in detail, but the point is this does not happen in your and my heart. This is an abnormal re-entry circuit created or present in the heart of a person who's usually going to be a young female. In fact, guys, this tachycardia that I'm teaching you at the moment, or this tachyarrhythmia causing problems for this patient, is usually seen in structurally normal heart. If you compare this with atrial fibrillation, remember what I told you, dilated cardiomyopathy, alcoholic, when I was teaching multifocal atrial tachycardia, then you will notice I will be talking about COPD patient causing dilatation on the right side of the heart and cor pulmonale. The point here is that if you are going to read about arrhythmia in a structurally normal heart, one of the points that you need to remember for arrhythmia in a structurally normal heart is the topic that we're studying, casually referred as paroxysmal supraventricular tachycardia, or PSVT. But because it's going to be very easy for you to answer PSVT, so he's going to use this word AVNRT, that is AV nodal reentrant tachycardia. Subsequently, I'm also going to teach you AVRT, that is atrioventricular reentrant tachycardia. So there are two terms which I want you to learn right in the starting of this discussion. One is AVNRT, second is AVRT. At the moment, it is AVNRT that is on the agenda. Now, let us create a case-based scenario on the same, and this patient will usually be a young female. And she's had recurrent episodes like this. It's not the first time that she's a doctor coming to a doctor. Maybe she came to me the first time, but she's been to many physicians even prior to me, and has even been to the psychiatrist because she was having this sensation of palpitations. She was having this dizzy spells. So she thought that maybe she's having some anxiety issues, and she's maybe on anti-anxiety medication as well. I highlight the fact that this arrhythmia can be present in structurally normal heart. So this young lady, she tells me that she was sitting with her friends at a coffee shop, like the lockdown eased off, so like people had not gone out, and she said, I just went casually with my friends to a coffee shop when I started taking coffee, and then suddenly I started having these palpitations. She's not blaming coffee per se, she's just casually telling you, but you have to understand that I would say caffeine per se or energy drinks can trigger episodes of PSVT in susceptible people. I mean, if you and me are going to have a strong coffee, no issues, because we do not have a reentrant circuit in our heart. This lady is having recurrent episodes of palpitations, and she also tells you a very interesting fact. She says, doctor, earlier one episode occurred where I became unconscious. And maybe my friends were laughing on me or were making fun of me, because you see, being young people becoming unconscious is not something routine, and take it from the non-medical's perspective. So she says that I don't feel very comfortable, doctor, when these episodes occur, or even if luckily she did not become unconscious, she was having this dizzy spells or dizziness present. So she says, I do not feel healthy, doc, and therefore I want to know what is wrong. So on listening to her complaints, I have advised her to get a ECG done. And in fact, when I told her to get a ECG done, maybe from a or maybe from a medical file, she took out multiple ECGs, and she says, every time I go to a doctor and I tell these particular complaints, they write me a ECG, and every time the ECG comes out to be normal. So would you like to see the older ECGs? I had a look at the older ECGs, they were normal. I said, no ma'am, still I want to get a fresh one done. Now when the report came, it was normal. So she's asking me, sir, I told you already that my ECG report will be normal. There's nothing wrong with my heart. And every doctor I go to, because I say I become unconscious, I have palpitations, they get a ECG done, but everything is normal, doctor. What is going on? Please tell me. I'll tell her, ma'am, I knew that your ECG will be normal. Now she is giving me a quizzical look. She says, if you knew ECG is normal, why did you get it done? Well, I cannot explain to her the concept of evidence-based medicine since she's a non-medico, but I want you to understand that I have demonstrated at the moment ECG is perfectly normal. But I'll tell her, ma'am, now with your permission, we will be putting a device on your chest which is going to record your ECG for next 24 hours continuously. Well, in this particular condition, lots of time when the patient will come to you, patient might be okay. There might be no problems in the patient. See, she started feeling dizzy after having coffee, and by the time she reached her clinic, she was okay. Or she was just feeling unwell, but otherwise, as such, in the clinic, she is not unconscious. So when I will put the Holter device on the chest of this person, I will be able to record the cardiac events over a longer duration, and that is when, because these 10 episodes tend to reoccur, we will be able to pick up the abnormality in the ECG. Now, what is the abnormality that will be picked up can be understood from this line diagram, so please pay attention to the slide. At the moment, I'm drawing perfectly normal. We all have a normal sinus rhythm. Every P wave will be followed by a QRS complex and then a T wave. Though I've exaggerated the sizes of the waves, what I want to tell you is that if the heart rate will increase, then the RR interval will reduce. Remember, I had taught you guys that heart rate and RR interval are inversely related. So now imagine when R and R wave will come closer to each other, then the T wave and the P wave of the subsequent complex will also start coming closer. And the closer these waves will be coming, then they can be merging of the T wave and the P wave as well. So let us now look at what's going to happen when I record or analyze the Holter device, or I download the data from the Holter device to my iPad or to my laptop using a software. I will be able to demonstrate that at some part of the day she had this event again. In fact, you can ask the patient, ma'am, please note down in a diary if you have an episode like this again. So she's in the subsequent visit also telling you, yes, doctor, in the evening or maybe at late at night, maybe I was watching a movie and I was sipping coffee and I had this episode again. Please do not be under impression it occurs only with sipping coffee. What I want to say is that with sympathomimetic stimulation going on, these attacks can rather be triggered, especially after caffeine intake. And now when I download the data, at a particular point of time, I'm noticing that the ECG is showing a narrow QRS. Along with narrow QRS, I will be able to notice some magnitude of ST segment depression. The wave that I drawn before you at the movement, I'll draw it again, is having rather or is created due to merging of the T and the P wave. By P dash, I mean the P wave of the next complex and the T wave of the previous complex. So let me just recreate this once again for you. And I want to say that PSVT, I personally feel, is one of the easiest ECGs to identify in any exam. I'll show you the exam-based image also, but I'm deliberately hand drawing at the moment so that you are sensitized to the abnormalities that can be seen. And well, what are the abnormalities that I want to highlight? First is that the distance between the R and the R is substantially reduced. And you know the formula for heart rate is 300 divided by RR interval. So usually you would get heart rate of 150 to 200. The second feature, which is very characteristic of this condition, is a narrow QRS complex. In fact, you see, normally whenever I draw QRS, I draw them very luxuriously. I mean, taking some space, taking some time, Q, then R, then S. And now when you look at the ECG that I've drawn in red, you can see that QRS is literally jumping on each other. Apart from this, I'm also highlighting the fact that there would be hidden P waves. Why I'm saying hidden? Because there's merging of the T and the P waves. And most importantly, you can also notice some global. In fact, you will notice this all over. Why? Because the heart will beat suddenly very fast. When you have a very fast beating heart, the oxygen demand will increase, but there's limited supply, no? I mean, there's a limited amount of oxygen available via the patent coronary arteries of the patient, and the demand is tremendously more. So because of the mismatch between the demand and the supply, there can definitely be some magnitude of ST segment depression present in a lot of ECGs of PSVT/AV and RT. The green is representing the global ST segment depression. What I mean by global is it could be present all over. That is all the 12 leads of the ECG. Now is the time for treatment of this particular person. So let's look at what we can do to prevent such aspects and what's going to happen if she presented in the casualty with an acute presentation like this. This is the actual image that I was talking about. So let me just zoom it in and make you more comfortable with this. One I have highlighted at the movement is relatively a narrow QRS. In green, I have shown some magnitude of ST segment depression, and then I'll use a different color to highlight this wave that is formed by the merging of the P and the T waves. You can notice that in green I've shown ST segment depression. Along with this, I've shown a relatively narrow QRS complex. You see the QRS duration traditionally should be about 80 to 100 milliseconds. Here you can see that it's literally about 1.5, or I will put it rather at one small square. That would be only 40 milliseconds. So that is definitely lesser than normal. If you want to track the heart rate of this person, you can simply do this activity. Look at the distance between the R and the R here. I can rate it at something like 1.5 large square. So 300 divided by 1.5, that is turning out to be the precise value that I was saying, that usually PSVT, the heart rate is in the range of about maybe 150 to 200. And therefore, the moment you see a tachycardia, the moment you see a reduction of the RR interval, narrow QRS complex tachycardia, a global ST segment depression, merging of the P and the T waves, you know that you're dealing with the AV and RT. The question now comes, what can you do to prevent episodes of paroxysmal supraventricular tachycardia? And I usually find a lot of guys casually answer adenosine. Please look at the question that I put up. I did not ask you the drug of choice for this condition in an acute episode. I asked you how would you prevent it from happening. So in this particular case, ideal method would obviously be that we can go for electrophysiological studies and we can go for destruction of the abnormal pathway. But if he just says what is the drug that you would give, then I would like to give a drug that will increase the AV nodal delay and decrease the rotational speed of this re-entry circuit. The circuit's movement was rotating at a high frequency. If I slam on the brakes, if it is going to rotate relatively slower, then SI node will take over the heart. So the drug that we can be giving to these patients on a long-term basis is verapamil. However, in an acute episode, the situation will be different. So let me just recreate this situation once again to you. In the exam, what he mentioned was that a lady was having palpitations. She became unconscious. She was brought to the physician in an unconscious state. In those circumstances, he's talking about management of an acute episode. Let's now look at what can be done for managing such a case. Again, don't straight away jump the gun and straight away answer adenosine. Have a look at the blood pressure values given in the question. If he himself tells you the fact that the blood pressure of the patient is unrecordable, if we are talking about a crashing patient, then we straight away need to give DC shock for the person. Then there is no role of drugs. So I want to make it very clear before you that do have a look at the blood pressure values. If the systolic blood pressure is given to be less than 90 or unrecordable, it is straightforward a DC shock. If the systolic blood pressure is equal to or more than 90, that is when the following maneuvers or the steps that I teach you will be used. If he says what is first line management, your answer would be I will be giving carotid sinus massage to the patient. In fact, carotid sinus massage will slow down the rotational speed again of the re-entry circuit and will cause improvement in the general condition of this patient. Please remember the fact that carotid sinus massage, when it is given, which nerve will be which nerve that innervates the carotid sinus will be stimulated. Then please remember that carotid sinus is per se not innervated by the vagus nerve. Carotid sinus is innervated by the carotid sinus nerve, and this is not a branch of vagus. You know very well from anatomy that carotid sinus nerve is a branch of the glossopharyngeal nerve. This is the afferent. It is the efferent. I'm just going to write the alphabet E. Efferent is vagus nerve. So when you give a carotid sinus massage to a person, the impulses go towards the brainstem via the carotid sinus nerve, which is a branch of glossopharyngeal, and the efferent, that is the vagus nerve, innervates the heart. It innervates the AV node. It slows down the re-entry circuit current. I'll just draw an anatomical diagram here to highlight that this can be taken as a representation of common carotid artery. This is the external carotid artery, then would be internal carotid. And then I've highlighted the carotid sinus as well. So when it comes to giving carotid sinus massage in a person, the doctor obviously has to be very clear about the site. That is one. This would be given with your thumb perpendicular to the angle of the jaw. That's where the internal carotid artery and the carotid sinus is going to be present. So one, they can obviously quiz you in the MCQ regarding the site and the physiological aspects which are related to the glossopharyngeal nerve and the vagus nerve. The site I said was perpendicular to the angle of the jaw, and whenever you're giving carotid sinus massage, you are supposed to give it intermittently on only on one side at a time. I mean, do not give it to both sides simultaneously, because that can contribute to sudden deceleration, even a bradycardia in some cases. So you give it on one side intermittently. If you will give continuously, it will cause desensitization of the receptors. I repeat once again, if you give it continuously, it can cause desensitization of the receptors. Now I'm going to create a bad situation here. At the moment, I'm not aware, but my patient is having atherosclerosis. So what I've shown here is an atherosclerotic plaque present in the internal carotid artery, and me as a physician is not aware of this, that the person is having a carotid sinus or rather internal carotid artery atherosclerosis. Now, if I will give a carotid sinus massage in a patient like this, I can actually result in, or I can contribute to development or damage to this atherosclerotic plaque, and the fragments of it can escape from here, and the atherosclerotic fragments, when they escape into distal circulation, they are going towards the brain. It will cause stroke in my patient. You see, one of the disadvantages, or rather I would say a side effect of carotid sinus massage would be that it is capable of contributing to stroke in an individual, that too of the embolic variety, because you caused damage to the atherosclerotic plaque. The plaque fissured, there was collagen exposure, platelets will jump onto it, clotting cycle will be activated, and all these fragments, or rather I would say the atheroembolism that is occurring in this case, can contribute to neurological features to develop in a person. So how, as a doctor, would I know whether somebody is having atherosclerosis of the carotid artery or not? Is with respect to this auscultatory finding, carotid artery bruit. You see, the moment you read the word carotid artery bruit, it per se means the fact that the person is suffering from atherosclerosis of the internal carotid artery. What I basically wanted to explain to you is that carotid sinus massage, the topic that we are studying, is absolutely contraindicated. in a person who's having carotid artery bruit. I repeat the fact once again. The question was regarding carotid massage per se only. They have talked about the physiology aspect, the afferent and the efferent, the anatomical aspect, that is where would you give it. Both sides are obviously not given, that you very well know, but I've just sensitized you to the fact that why do you read in the textbook that carotid sinus massage is contraindicated in patients with carotid artery bruit, because it implies that he's having atherosclerosis, and God forbid if a doctor does this activity on a person with a known atherosclerosis of the carotid artery and he did not, or was not aware of this, then person can develop neurological complications as well. At this junction, I also want to highlight that when they ask you about the pediatric domain of PSVT, like they can talk about a child also, no, who's having a PSVT. Lots of time in children, infections can trigger PSVT in a susceptible child. I mean, child is not going to drink coffee or energy drink, right? So, especially with respect to pediatric paroxysmal supraventricular tachycardia / AV and RT, he may not be even giving carotid sinus massage in the choices. Why? Because children have a short neck. Because the neck of a child will be short, surface marking will be difficult. You see, in you and me, the neck is relatively big. You can see the muscles, so you can do bit of surface marking. But in children, because the neck is short, especially if the child is plump and obese, then the neck will be relatively short, so surface marking will be relatively difficult, or rather I would say error prone. You might be pressing at the wrong side. So what he's suggesting is that when it comes to pediatric cases, and you can use it in adults also, not a problem, not a hassle, face ice pack. If you do not have a conventional one, no, just in a pair of gloves, you can take ice from the refrigerator, put it in a pair of gloves, and you can apply it. So face ice pack can definitely be useful, again because it will contribute to vagal stimulation. So remember the fact that there are multiple other methods of also causing vagal stimulation, including Valsalva maneuver or even oculocardiac massage. For the last one, I want to say that this is usually not a very recommended one. Why? Because you could actually cause trauma to the tissues of the eyeball. So for any untrained person, first time doing oculocardiac massage is obviously not advisable. But at this juncture, I have taught you regarding 4 different methods of causing vagal stimulation. The methods are the traditional one, carotid sinus massage, face ice pack, Valsalva maneuver, and oculocardiac massage. Wherever he gives you a preference. I mean, first answer is obviously carotid sinus massage, but like I said, for a pediatric scenario where neck is shorter, you will then have to answer it as face ice pack. Now, moving ahead in our discussion, this is initial step. This is the first step in a person in whom the BP is relatively stable, that is equal to or more than 90. Now, because this is not a permanent solution, so I will have to go in for chemical cardioversion. This chemical cardioversion will be done with the first shot of adenosine 6 milligram. If it is not working, the next shot would be 12 milligram. In between this, if BP becomes unrecordable, you straight away go to DC shock. At any point of time, if the person BP will crash, in those circumstances, straight away a cardioversion or a DC shock has to be given to the patient. But yes, if the BP is stable, you first will be giving 6 and then 12 milligram, total of 18 milligram has been given. But let me say, even then, the arrhythmia is persisting. You have done chemical cardioversion already in the person, and in fact this is the scenario again. One was unrecordable BP, you go in for electrical cardioversion. Now chemical cardioversion is failing, so what will you do? You will again go in for giving DC shock for the person. So here, instead of writing DC shock, I'm writing the word electrical cardioversion. The intensity of DC shock can obviously vary. Like for atrial flutter, I taught you 25 to 50 joules. For atrial fibrillation, I said 200 joules. For electrical cardioversion in a PSVT, the range is 120 to 200 joules. All the models that are available nowadays will be delivering biphasic DC shock, and this DC shock will always be called as synchronized DC shock. I want to make it very clear before you the fact that what do you mean by the word synchronized DC shock is that the computer will fire the impulse. Listen to this part very carefully, though it is taught in anesthesia also. The meaning of the word synchronized DC shock is the computer will fire the impulse at the peak of the R wave. You will also read about terms like non-synchronized DC shock. You will read about synchronized DC shock. So synchronized basically means at the peak of the R wave, the computer will automatically recognize the R wave. In this case, it will be narrow QRS complex tachycardia. Because there is an abnormal contraction. When you give the shock, the abnormal contraction will be terminated. the heart will relax, get filled with blood, and SC node will take over the activity again. I want to suppress the bad guy. I want to suppress the re-entry circuit by giving electrical cardioversion right at the peak of the R wave. Why? Because that is where the abnormal contraction is occurring. The moment I deliver a DC shock, the heart will relax, get filled with blood, and SC node, the dominant pacemaker, will take over the activity because the bad guy, the re-entry circuit, has definitely been suppressed. The message here is that whenever you read the word synchronized DC shock, synchronized DC shock is also referred to as cardioversion, whereas non-synchronized DC shock is the one that is referred to as defibrillation. I usually get a lot of queries from my students that, sir, cardioversion kya hota hai, defibrillation kya hota hai? Both of them are separate. Cardioversion basically means synchronized variety, defibrillation means the non-synchronized variety. And as we progress in the discussion, you will feel relatively more comfortable with this. And I would like to just highlight this fact once again for your practice so that this becomes permanent memory for you. So listen to the next aspects very, very carefully. In majority of MCQs, he will give you a scenario of AV, NRT, AV nodal reentrant tachycardia, and there are three domains which are to be answered by you. One is going to be management of an acute episode. But in this case, with acute episode, the systolic blood pressure of the patient is at least a respectable value. Second is going to be acute episode or a crashing patient with unrecordable blood pressure, and third aspect would be prevention. Now, the answers will obviously vary. If it is a crashing patient, I straight away will be giving synchronized DC shock to the patient. I mean, I'll just need to attach the paddle through the chest of the patient and adjust the settings in the computer. Once I put the settings on synchronize, the computer will pick up the peak of the R wave automatically and deliver the DC shock. The message is this synchronized DC shock per se, the intensity can range between 120 to 200 joules biphasic, and you can crank up the power. You can turn the switch and increase the power if the first shock is not working. Usually it would. In an acute episode where the blood pressure is at least respectable, first answer is carotid sinus massage. If it does not work, well, adenosine, and subsequently, if it still does not work, you will have to go for synchronized DC shock again. So these are the steps in the sequence that he would love to ask you for a person who's hemodynamically stable. For the prevention of an episode of AVNRT or PSVT, I can obviously use verapamil, but the tablet is something that can be forgotten by the patient. So what I can do is at the moment first do electrophysiological studies. EPS is a special study which can map out the heart, which can actually track the flow of the current, like I was saying, retrograde conduction, antegrade conduction. So routine ECG electrodes cannot pick it, but we have special electrodes by which we can map out the heart, we can pick up the ectopic foci, we can map out the flow of current, whichever way it's gonna flow in the heart, and then we can definitely go in for ablation of this abnormal circuit which is contributing to re-entry phenomenon. Now, as I've highlighted, if you are gonna get both ablation and verapamil in the MCQ, your first answer is obviously a permanent solution, and then can be verapamil. Yes, sometimes even after ablation there can be a recurrence. We can manage it with help of verapamil, but these are the single best answers that I've just highlighted before you. So let's get the facts together. Acute episode, hemodynamically stable, carotid sinus massage. Do not answer carotid sinus massage if the person is having atherosclerosis of the carotid artery. So keep a watch for that, because if he's himself gonna tell you that this guy had an embolic stroke, he's a known case of chronic stable angina, if he's himself giving you situation for atherosclerosis, then you obviously need to be wary. And if he's himself telling you person is having carotid artery bruit, in those circumstances, again, carotid sinus massage cannot be given. So this is the treatment algorithm that is to be remembered. And I just wanted to sensitize you to the fact that don't straight away in the multiple choice answer is adenosine, because he knows that you know answer as adenosine. He's gonna try and ask you the aspects that I have highlighted in this flowchart. I mean, if you get this flowchart right, you will be bang on target to solve MCQs with respect to this particular topic. The next topic that I'll explain to you is called as AVRT, that is atrioventricular reentrant tachycardia. So reading the question is of paramount importance, though there are two line diagrams which are already mentioned before you from the textbook, but I would like to hand draw them before you so that I can actually explain the concept. You see, first I'll be drawing the normal conduction system in the heart, so please be patient for it. I have already explained to you that the two sides of the AV node do not conduct at the same speed. They can have a fast slow pathway or a slow pathway, and ultimately the bundle of His is activated, and that is how the normal conduction system of our heart will be working. I've also highlighted the Purkinje network, which will now be innervating the myocardium, and the impulses will be spreading from the inside to outside and will cause a ventricular depolarization. I've now added an abnormal circuit in the heart of this patient, that is bundle of Kent. And the highlight of this bundle of Kent is, and that's the key of this discussion, that it can conduct both ways. You see, in our heart, the current will always conduct in a forward way, that is antegrade conduction. But the speciality of bundle of Kent is that not only is it fast conducting, but it can conduct forwards, that is antegrade, or it can even conduct retrograde as well. So at the moment, what I'm going to show in this case is a forward conduction. The arrow here is showing that the current is bypassing the AV node. This current will directly activate the ventricles. In fact, you would be wondering why am I talking about this topic of Wolff-Parkinson-White disease once again, is to sensitize you to the fact that at the moment there is a antidromic conduction. Well, how do you remember this word antidromic? You can just go by the alphabet A. It is antegrade conduction which is occurring across. Now compare this with the line diagram once again. So you need to compare the second diagram that I make before you. At the moment, everything is still the same, but there will be minor difference which I would like you to pick up, and that will be the key point of this particular discussion. I once again introduced the bundle of Kent, but this time what I'm saying is, and follow my arrows very carefully, the current at the moment did not go via the bundle of Kent. There is a possibility that at the moment of Kent, the bundle of Kent was refractory. So the current went the normal pathway, that is went across the two sides of the AV node with variable speed, caused a septal activation. The current has now entered into the left and the right fascicle, is now spreading into the Purkinje network. So you can see that the current will definitely get access to the myocardium per se. Everything is so far so good. At the moment, there is no problems per se. The current is very well traversing into the myocardium from the inside, that is endocardium, to the epicardial side. But some of this current, I'll just zoom it in, some of the current is actually re-entering via the bundle of Kent. In green, I have at the moment highlighted what is a reverse conduction occurring in the bundle of Kent, and this is called as orthodromic. Now to help you remember, I can use a Hindi word here also. You see, when I say the word ulta, ulta basically means reverse, reverse means retrograde. So ulta rhymes with the word ortho, ortho matlab ulta ja raha, right? So I'm just trying to rhyme a word here for you to make you remember the fact that whenever you read the word orthodromic conduction via the bundle of Kent, it highlights that there is a reverse conduction that is occurring. Now there are two circuits which have been shown here. At the moment, in the first conduction, or in the first diagram, I can say the current is entering into the heart via the bundle of Kent, and then per se there is a intermyocyte conduction, and you are very well familiar about the fact that intermyocyte conduction speed is always lesser as compared to Purkinje fiber. As a result of it, the ECG of this person will be showing a broad QRS complex. I want to say that re-entry circuits occur with respect to bundle of Kent also. At the moment, in both the diagrams, I have shown an accessory pathway. In the first diagram, the accessory pathway will be conducting antegradely. So the current is going to enter into the muscles via the bundle of Kent, but then can spread in a reverse direction. The same current can travel in a reverse direction. This does not happen in your heart, but in this particular person, the current can re-enter via the AV node. In the second diagram, what is happening is the current is traveling forwards via the AV node and is then going in reverse direction. You can notice the green arrow here. It is going in reverse direction and is causing a re-entrant circuit once again. However, in the second one, because the current is utilizing the normal circuit, current went via the AV node, Purkinje fiber was used, and there could be a faster conduction occurring. So this would be having a narrow QRS complex. I wanted you to be aware of the fact that the topic that we are at the moment discussing is called as AVRT. I have already said the name, but you can see now the connection is between the atria and the ventricle directly via the bundle of Kent. So when you read the term AV and RT, then there is no accessory pathway. Then there's going to be only re-entry circuit across the AV node, but this time the word is atrioventricular re-entrant tachycardia, and the highlight of the discussion is that AV-RT can have two possibilities. It can be broad QRS also, it can be narrow QRS tachycardia also present. In contrast, when I was teaching you regarding AV and RT per se, AV and RT will uniformly have a narrow QRS complex. I repeat the fact once again, whenever you read the word AV and RT, it implies it will always be narrow complex. But when it comes to AV AVRT, that is atrioventricular, because the current is directly going from atria to ventricles. It can either go via the normal circuit or via the bundle of cat. If it goes via the normal circuit, that is the traditional one, then we call it antigrade, that is antidromic conduction. But if it goes ulta, then we call it orthodromic conduction. These two terminologies have been added to your vocabulary of Wolff-Parkinson-White syndrome. The main crux of the discussion again is WPW can conduct both forwards as well as backwards, so you should be familiar with the terms. And the speciality is WPW. Anyway, told you there's going to be broad QRS complex due to intermyocyte conduction. I've taught you a peculiarity that with Wolff-Parkinson-White syndrome there can be a narrow QRS complex tachycardia also. How? Only if there is a retrograde conduction. In the actual topic of WPW in ECG and Arrhythmias part 1, this is the diagram that I made before you, antidromic conduction only. But at the moment, I've expanded your knowledge base or your vocabulary base by also incorporating ulta conduction or reverse conduction also, that can contribute to narrow QRS. Why narrow QRS? Because Purkinje will be utilized in this case, and if the impulses travel faster via Purkinje, they can be narrow QRS complex developing. The re-entry circuit in this case is via the accessory pathway. The blue circuit which has been shown here, as you're aware of, but WPW will be bundle of Kent. So that's an additional detail that I want you to remember. The next topic that we'll be discussing is again a hot favorite of our examiners. This is broad QRS complex tachycardia, and we're going to talk about two varieties of it, the monomorphic and the polymorphic variety. And first I'm going to focus regarding the traditional one that they love to ask, ventricular tachycardia, commonly written as VT. Let us try to understand what's the problem in the heart of this person as compared to yours and mine. So I'm drawing these sketches once again, or this normal circuit once again, just to sensitize you to how the problem will occur in this person. So let us imagine this person had a myocardial infarction. He has luckily survived. You have maybe even thrombolized this guy or done a primary PCI, but unfortunately due to damage in the heart, due to ischemic damage in the heart, there is a creation of an ectopic focus, and this abnormal focus is firing at a very fast rate. Let me say, though the ectopic focus can fire at any rate, I can incorporate any fast rate between anything between 200 to 300 per minute. Just I will be rather considerate and introduce a lower rate of 200 per minute. Now this is very fast and is going to cause problems in the heart. How? Because the SA node of the patient will definitely be able to control the atria. But you see, the ectopic focus is firing much faster. The ventricular rate of the patient will definitely not be maximum 100 per minute. The ventricular rate will be 200 per minute. Why? Because it is the ectopic focus that will be controlling the heart. And how this ectopic focus will fire? When it will fire, it will not utilize the Purkinje network. You see, the current is not going via the normal way. So Purkinje network is not going to be used in this condition. As a result of it, once again, I'm using the word intermyocyte conduction. And this intermyocyte conduction, guys, explains the fact that why do you always read the word broad QRS complex? Remember, I told you Purkinje's fastest, intermyocyte conduction will be relatively slower. The word is slower, so there will always be a broad QRS. On listening to this, the query of most of the doctors is that, sir, you are saying ventricular tachycardia. In tachycardia, should it not be a narrow QRS complex? Please appreciate that tachycardia is not decided by the duration of QRS. Tachycardia is decided by the RR interval. If the RR interval is lesser, that implies tachycardia. QRS complex can either be narrow or can be broad in a tachycardia question. I repeat the fact once again, heart rate is not decided in the ECG by the duration of QRS. It is the RR interval that will decide the heart rate of an individual, and tachycardias per se, which will have a short RR interval, can either be narrow QRS complex or broad QRS complex. The logic is, if it is narrow QRS complex, it's mainly going to be a supraventricular tachycardia. Whereas whenever you read about broad QRS complex, this broad QRS complex is the topic that I'm trying to explain to you at the moment, that is written to as VT. Now, there are two important reasons why the blood pressure of this person can crash. The first and the foremost problem of this person is that the atrial rate is 100, ventricular rate is 200. The two are not matching. I taught you atria should contract first, then ventricles. Atrial and ventricular rate should be equal. But in this patient, one of the big problems that has suddenly crept up is that of AV dissociation. When I was discussing bradyarrhythmias, AV dissociation was discussed for complete heart block. The tachyarrhythmia that I'm teaching you, where there can be AV dissociation present and even super large A waves, that is Canon A waves, is gonna be the current topic. Apart and over this, I can also say that the person is having a pathological tachycardia. Why? Because I have taught you that maximum heart rate possible for a normal human being is 220 minus age. Remember congestive heart failure topic? If you have not read it, I'm gonna say this again. Physiologically speaking, asking, if he says, what is the maximum ventricular rate possible for a normal human being? The word is physiologically speaking, it is 220 minus age. But if a person of 60 years of age is having a heart rate of 200, it is not normal. You see, if you look at the formula, the maximum physiological ventricular rate for a 60-year-old man will be 220 minus 60. That would be something in the range of 160 per minute. But if a 60-year-old man post-MI is having a heart rate of huge 200 per minute, it is a pathological tachycardia. And what is the problem with pathological tachycardia? Heart will get less time to relax. If it will get less time to relax, less will come in, less will be going out, and therefore the BP of this patient will crash. Majority of multiple choice questions of this particular topic will always prefix this word, and I'm going to prefix this word right now, that is pulseless VT. It is always written as PVT. Even in the emergency medicine section, you will see me writing the word PVT multiple times. That pulseless ventricular tachycardia, why is it occurring, is due to the two reasons I just explained to you. Lack of coordination, because atria and ventricles should fire at the same rate. Second, there's a pathological tachycardia. The combination of the two can cause death of this person. Unfortunately, though we had treated this MI case with a thrombolysis of PCI in the stipulated duration, but this patient can deteriorate and can actually die. So let us now look at what can be done for management of these patients. The first and the foremost, and I can hand draw a rhythm here before you, before I actually comment on the real-time ECG of the person. Let us assume that the person had a non-ST elevation variety of MI. So I've just highlighted in this case a T-wave inversion. The treatment of the person was done. Now in the recovery unit, in the coronary care unit, you are noticing that the ventricles are contracting much more faster, but at the same time there will be a broad QRS complex. So if you look at the RR interval, definitely I've tried to make R and RPT close to each other. You cannot decipher any P wave, you cannot decipher any T wave, because it is just that the ventricular contraction or the activity of ventricles which is faster is dominating or is being read by the surface electrodes. Majority of the questions will actually give you broad QRS complexes, or he might use the word premature ventricular contractions. Now, as the arrhythmia will pick up speed, there is a possibility that in some of the I would say the recordings that are given to you in the exam, or I'm hand drawing before you, you will notice the fact that in the downswing of the S wave, you can notice that at the moment the S wave is going down. I mean, anything that goes up is R, anything that comes down is S. So in the downswing of the S, there might be a notch present. This notch is what is called as Josephson sign. I'm going to hand draw one more rhythm here before you, in which may or may not be visible. I mean, that's obviously at the discrepancy, or I would say the depending on the examiner whether he wants to incorporate the next aspect that I've highlighted, that the bundle branch block kind of a pattern. Like you can notice a rabbit ear pattern that I've shown in this case. Well, why there's a rabbit ear pattern is because there's an intermyocyte conduction occurring, and you will also notice the fact that rabbit ear should be symmetrical, but in this case it will be asymmetrical. In bundle branch topic, or left bundle branch block or right bundle branch block topic, you will hear me talking about rabbit ear appearance, but I have drawn the two ears of the rabbit relatively equal in size. But in this case, that is ventricular tachycardia, you will, if he gives you in the exam, it will be asymmetrical rabbit ear appearance present. There's also possibility that in between the rhythm might actually become perfectly normal. There's a chance that by the time this ectopic focus captures the heart again, the SC node might sneak in one or two impulses. So in between the rhythm might become normal also. That might actually cause a bit of confusion for you, because everything was going abnormal, then there's suddenly a normal rhythm present. But then you notice that the ECG really goes crazy, in a sense that you lose the Josephson sign, you lose all this rabbit ear appearance. All you get is this kind of a sinusoidal appearance present. Well, first and foremost, I want to highlight what is given in the textbook as warming up. Like an athlete will do warming up. Now you will do some stretching exercises before you actually start doing a workup. So similarly, in this case, in the textbook, he describes warming up of the arrhythmia, that the arrhythmia is taking up or is picking up speed. If you look at the RR interval initially, and compare this with the RR interval subsequently, you will notice that the RR interval has even become relatively lesser. So that is what I meant by the fact that the arrhythmia is picking up speed. Or like you can see, a train starts from an engine. When the train will start from the station, then initially when the engine will generate power, then initially the speed of the train will be slow. Then it keeps on pumping more power, so the speed tries to dramatically increase. Similarly, here I'm saying like a train leaving a station, it will pick up speed gradually. This arrhythmia is also picking up speed. Well, what are the highlights? There were a lot of things I said, so let me just summarize them for you. First and the foremost, whenever you read the word premature ventricular complexes, well, what is the important of premature ventricular complexes is that if the ventricles will contract earlier than what they ideally should, they will never be filled up with blood, and therefore if input is less, output will also be less. If in any ECG you get consecutively 3 or more than 3 premature ventricular complexes with a heart rate of more than 100, and this is sustained for more than 30 seconds. Now I'm not writing the 30-second criteria because the technical aspect is VT might sometimes be terminated on its own within 30-second period. If it is terminated within 30-second period, we call it a non-sustained ventricular tachycardia. If it is persisting beyond, then we call it a sustained ventricular tachycardia. 30-second period I'm not writing. All I'm saying is, in this particular case, there are more than 3 premature ventricular complexes with a heart rate of more than 100, which is one of the working definitions of VT. In fact, in some MCQs, he might just use this term, which I want you to definitely remember, because this is a very easy pickup point in the MCQ. Broad QRS complex tachycardia, wherever written in the MCQ, whatever else might be given in the question, whatever paraphernalia, I mean, this particular terminology highlights that you should call this as a ventricular tachycardia, or think in terms of a ventricular tachycardia. I have already sensitized you to the fact that heart rate is dependent on the RR interval, and in this case, the reason for broad QRS complex is the intramyocyte conduction, which will be relatively slower as compared to what the Purkinje will be doing. In fact, in some of the ECGs, you might be getting what is called as Josephson sign. Josephson sign is the rather this notch, or I would say this shelf kind of an appearance that was present in the downswing of the S wave. So I'm just going to put an arrow here to say that Josephson sign has been highlighted. Over and above this, I have also highlighted this rabbit ear appearance, but it would be a asymmetrical rabbit ear appearance. This again indicates that since the normal conduction system is not getting utilized, so therefore bundle branch kind of morphology can be present, and they would not be a simultaneous activation of the ventricles. I mean, yours and my left ventricles and right ventricle will contract at the same time, but in this case the discrepancy will be there between the firing because the current is not coming by the normal circuit. The word is asymmetrical rabbit ear appearance. Now this may or may not be given. Another interesting finding is in between this marking that I've done, you might get a normal sinus rhythm. This particular area that you getting a normal sinus rhythm may be written in the MCQ as a capture beat. So when you will read the criteria for diagnosis of ventricular tachycardia, there will be a lot of literature given, but at least if you focus on the word broad QRS complex tachycardia, capture beats, or they have written a sinusoidal appearance, then this would definitely help you in cracking the question. In fact, I would like to highlight that PSVT and VT ECG is one of the most common rhythms that they've always or usually have given in the exam. So if you ask me that, okay, what arrhythmia should always be studied at least 1 week before the exam from the treatment domain, that PSVT and VT are always to be studied. Apart from this, another feature that you will always read written in the literature, and I have explained this concept in the earlier part of the discussion, is EAD, that is extreme axis deviation. You can go to ECG and Arrhythmias part 1 where axis calculation has been explained to you. Now let us look at what we can do for management of this particular person, and I can just show you this ECG tracing once again. I mean, really a broad QRS complex coming up in this case. I mean, if you look at the RR interval, it's hardly 1.5 or even lesser than 1.5. So heart rate of this person is dramatically pretty fast. Ventricular rate is about 200 per minute. That explains why I said BP will be crashing. I hope you remember that in physiology they teach that whenever heart rate will increase, BP will increase. But because this is pathological tachycardia, that is why the BP is crashing in this case. That is why I said the patient would be having a pulseless situation. Over and above this, in some of the tracings, you might be noticing a slight shelf present that I have just marked here before you. That is the Josephson sign. And a couple of my students, when they got this ECG in the exam, they were easily able to pick it up. Let me just do it at one other place, right? That's gonna be again a Josephson sign present in this case. This is the shelf that I'm talking about in the downswing of the S wave. Now, once you're able to pick up the rhythm, what will you do for PVT? Then the answer is DC shock. But the point is, at the moment, the configuration of the R wave is not like normal. So there's a possibility that the computer will not be able to pick it up. For pulseless ventricular tachycardia, we always go in for a non-synchronized DC shock. I want to repeat this fact once again. Whenever in the multiple choice question he mentions the word PVT, that is a pulseless ventricular tachycardia, your answer will be I will be delivering a non-synchronized DC shock to the patient. Instead of non-synchronized DC shock, he can also write the word defibrillation, but do not make comment about cardioversion, because cardioversion is synchronized variety and defibrillation would be in the non-synchronized variety. Once you get a hang of this, in the exam to trouble you, he would like to rather test your pharmacological domain. So he might write the word stable VT. The moment you read the word stable ventricular tachycardia, what does it imply? It implies that at the moment the arrhythmia started and the BP of the patient is at least recordable, or at least I would say critical reduction in blood supply of the coronary arteries or of the brain or of the kidneys has not occurred, since the systolic blood pressure is more than 90. So in these circumstances, what am I going to do? I'm going to straight away give amiodarone for the patient. Yes guys, amiodarone was also taught to you during management of atrial fibrillation and atrial flutter. In fact, I can highlight once again, amiodarone is a broad spectrum antiarrhythmic drug. Like you read about broad spectrum antimicrobials, I'm teaching you at the moment broad spectrum antiarrhythmic drug that can be given in this case. Now to trouble you even further, he can even write the word post myocardial infarction ventricular tachycardia. Then the answer should be given by you as lignocaine. Now this has been seen after clinical studies that lignocaine efficacy is relatively better as compared to VT for management of VT when it comes to especially hypoxia, especially ischemia, but there can be other reasons also. It could be metabolic acidosis, for example. It could be electrolyte imbalances occurring in a person. In those circumstances, amiodarone has been found to be relatively more superior. The intensity of the DC shock would be 200 joules biphasic. So do remember the fact that most of the MCQs will always write the word biphasic, and as I explained to you, most of the models that are available at the moment, especially all the automated external defibrillators that are available nowadays, will deliver a 200 joules biphasic to the patient. The main highlight of this discussion is also to notice the fact that the height of all these broad QRS complexes is equal. Therefore, if you wish, you can add it to the notes, or you can just remember the fact that the current ventricular tachycardia rhythm that I've explained to you is not only pulseless, but I've just said that because the amplitude of each one of these is almost equal, I've added a prefix monomorphic ventricular tachycardia. This can make you understand the fact that next that I'm going to explain to you is polymorphic, where the size of each one of these, here you can notice the size is more or less equal in all of them. The size of the next arrhythmia that I'm going to explain to you will be almost different. One will be totally different from another. So let me just hand draw another rhythm before you. This time I'm describing a patient with an electrolyte imbalance. Now, what kind of electrolyte imbalance? I will tell you in a while. At the moment, all I'm saying is that if you get a ECG of a sinusoidal pattern, and if you're noticing that the height and amplitude per se of these QRS complexes is varying, I mean, the way I have drawn it, this makes it relatively easier for you to comprehend why they call it polymorphic ventricular tachycardia. And since our examiners love these fancy terminologies, so one of the fancy terminologies to be remembered is called as TDP, that is torsades de pointes. I want you to remember the fact polymorphic ventricular tachycardia is usually seen with conditions that cause prolongation of QT interval. Let me explain this to you, what I mean by prolongation of QT interval and what will be the problem present here. One of the highly asked or important aspects of torsades de pointes is the reason it is usually seen with electrolyte imbalances, and the examiner loves to ask this. You see, if they ask you what is the cause of death in hypokalemia, then it is usually diaphragmatic paralysis, respiratory muscle paralysis. But if he says which arrhythmia is seen with hypokalemia, answer is the topic that we are studying. 3 electrolyte imbalances which they love to ask for this particular topic is hypokalemia, hypomagnesemia, and hypocalcemia. I know hypocalcemia can even cause tetany, in fact can cause death due to laryngospasm, but it has also been documented to cause torsades de pointes. And in all these 3 conditions, you will always notice that in the ECG, the QT interval will be prolonged, and whenever QT interval is relatively increased, then they can be fatal arrhythmia in the form of torsades de pointes. Just to make you comfortable with this, remember we do not usually, or we avoid giving hydroxychloroquine. You see, hydroxychloroquine was initially rather mentioned as the ultimate cure for COVID-19, but then you would have read reports of doctors who were having pre-existing heart disease taking hydroxychloroquine thinking that they can be protected against COVID-19, and they died. Well, what really happened? Hydroxychloroquine can contribute to QT interval prolongation, and that is why ECG must always be done and QT interval specially checked, especially when hydroxychloroquine needs to be given, whether it's for rheumatoid arthritis, whether it is for COVID-19, but that's a separate issue. But I want you to say that whenever QT interval is prolonged, it increases rather the action potential duration, that is okay, but at the same time, it also increases or makes the heart relatively more vulnerable to any extrinsic influences that can cause a tachyarrhythmia. In fact, a lot of drugs have been incriminated, especially in COVID-19, because initially you are not aware that COVID-19 is present because testing was not being done. So we were treating patients empirically with erythromycin and hydroxychloroquine. I want you to remember, erythromycin with hydroxychloroquine should never ever be given because erythromycin itself can cause QT interval prolongation and can contribute to torsades de pointes. In fact, some of the drugs that have been banned from the market and you would have read about is cisapride. Like we have etopride, we have bozapride available, but you never read about cisapride. It was banned because it was causing torsades de pointes. Similarly, there's an antihistaminic drug. This antihistaminic drug was initially present in some cough syrups. Estamizole, terfenadine was another one. All of these have actually been banned primarily because that they can cause a QT interval prolongation and can predispose to arrhythmogenic, or rather make the ventricular myocardium unstable. The message is that when it comes to polymorphic ventricular tachycardia, it is the etiology that is more frequently asked as compared to the ECG. In all other tachyarrhythmias, I've been very focused with respect to the ECG parameter, but you will notice whenever questions on this topic will be coming, they would rather love to know about the etiology part. In fact, what I'm saying next will sound even more surprising if you're reading it for first time, that class 1A, class 1C and class 3 antiarrhythmics can also contribute to TDP. On this, the query of most doctors is, sir, how is it possible? You are saying antiarrhythmic drugs are causing a arrhythmia. Antiarrhythmic drug is supposed to treat a arrhythmia. Guys, antiarrhythmic drugs can be a villain in a hand of a doctor. They can be an angel in the hand of a doctor. What I mean by angel is they will cure a arrhythmia. But what I mean by the word villain will be they can themselves trigger a tachyarrhythmia. And again, when you read pharmacology, basic sciences, you will notice all these arrhythmias also, or all these drugs per se, cause a prolongation of QT. And if you use too much of the drug, the QT prolongation might make the myocardium unstable and trigger torsades de pointes again. So etiology wise, be very, very thorough with this particular topic. Now I want to highlight the ECG features of this condition. Most of the time when he will ask you the ECG of polymorphic ventricular tachycardia, he will deliberately not ask you about the aspect of variable amplitude of the broad QRS, because that is fairly easy. I want you to remember this terminology that I am saying at the moment, QTC prolongation. Well, I was talking about QT, no? Now I'm saying about QTC prolongation. So what does alphabet C stand for? This is just a mathematical term. He just wants to see whether you're aware of this or not, that QTC corrected means QT divided by the root of the RR interval. In fact, this is itself a formula that has been asked, that QTC signifies, that is QT divided by root of RR interval. Whenever you read about QTC prolongation, that's an important or easy way to crack this question of torsades de pointes, assuming that you are not able to remember the etiology of electrolyte imbalances or the drugs that I was talking about. Apart from this, the standard features will anyway be present and can be visualized on the slide at the moment. They would still be. You can very well notice the QRS complex does not look like a QRS complex. It is relatively broad. And the distance between the 2 points, that is R and R interval, is substantially reduced. So whenever I say the word broad QRS complex tachycardia, this signifies that my patient is going to deteriorate very fast. One of the highlights of this would be that the amplitude of, you can notice when you scroll from left to right, the amplitude of this broad QRS is different. That is why the word polymorphic was introduced, whereas the previous ECG that I showed to you was rather having a uniform shape or uniform amplitude of QRS complex. So I said the word monomorphic. Whenever you are attempting questions, please remember the following fact. When you will go through the endocrinology component, you see, I want you to remember calcium and QT in ECG have an inverse relation. So in a MCQ tetany, you will always read the word QT prolongation. I repeat the fact once again, tetany can cause death due to laryngospasm. But tetany MCQ will always have this word QT prolongation, vice versa. Hypercalcemia MCQ will always have the word QT shortening. At the moment, I want you to remember that if he says the word QTC prolongation, then you need to answer this as Torsades de Pointes. You can see, sir, that a small alphabet C is making one hell of a difference in the answer. If you read the word QT prolongation plain, that is tetany. But if he says the word specifically QTC prolongation signifies, then that's one of the important diagnostic criteria for Torsades de Pointes. We will now be studying regarding what is the treatment that is going to be offered to patients of TDP. Well, the drug that we will use here will be magnesium sulfate, and I think most of you are already aware of it, and it's pretty straightforward. Magnesium sulfate has also been discussed, or you would have read it even in OBGY with respect to management of eclampsia. It will relax the blood vessels and will control the blood pressure of the patient. Even in a person of asthma, you see, asthma can be having acute asthma, severe acute asthma, that is status asthmaticus, and then even an impending respiratory failure. So when you will listen to the asthma discussion in the pulmonology section, you will again hear me read or speaking regarding magnesium sulfate. So there are three important uses of magnesium sulfate that you are aware of at the moment. That is eclampsia, impending respiratory failure, that is in a person with severe acute asthma, which is deteriorating to the level that this person will require ventilatory support, and Torsades de Pointes obviously. If he begins by describing a TDP patient who's pulseless, then it will obviously be it would be a DC shock that would be given to the patient. And since in this case also the computer may not be able to identify the peak or the R wave because it may be relatively broader, so therefore this would again be a non-synchronized DC shock. But majority of MCQ, especially for this topic, they deliberately want to hear about the drug per se. I just want you to be careful about the fact that do read the blood pressure value in every tachyarrhythmia MCQ. The cutoff to be taken is 90 millimeters of mercury. If it is lesser, or if he's himself saying the word crashing, no problems, then jump all the steps of pharmacology. No need for any drugs. Straight away go in for DC shock. Just take care of the synchronized and the non-synchronized version. I'll compile a list before you. When do you give synchronized? When do you give non-synchronized? But at the same time, drugs are also important. So the main carry home messages from Torsades de Pointes MCQ per se will be one, QTC prolongation and the usage of magnesium sulfate. And the third take home message would be the causes, because etiology normally is asked primarily for Torsades de Pointes only. And very surprising thing I mentioned was with respect to antiarrhythmic drugs. As I said, antiarrhythmic drugs can be a villain in your hand. They can be, an angel, or they can be a villain. Depends on how you use them. If you use too much of anything, it can be toxicity. If you can use it in the prescribed dose, yes, it will definitely cure the patient. Now, since I've explained to you regarding narrow complex tachycardias and broad complex tachycardias, what I'm going to do next is hand draw each one of them, and I would like you to take a paper and a pen and try to hand draw this activity with me. I will be talking about ECG findings with respect to atrial fibrillation. Then we will talk about atrial flutter. The minor aspects obviously need to be taken care of. Then is AV nodal reentrant tachycardia, which is also referred as PSVT. I will speak about Wolff-Parkinson-White syndrome, that will be having an antegrade as well as a retrograde conduction. Then is ventricular bigeminy. I hope you can recall this even from your pharmacology classes, that one of the commonest arrhythmias that we see with digoxin toxicity happens to be ventricular bigeminy, and the same patient of ventricular bigeminy can then degenerate into VT. And in ventricular tachycardia, because of the combination of AV dissociation and simultaneously the pathological tachycardia, the person can become pulseless as well. When I talk about ventricular tachycardia, I imply monomorphic, but we can also have a polymorphic VT that is called as Torsades de Pointes. And then obviously ventricular fibrillation will be talking about. But what I want to highlight for atrial fibrillation is that you will notice absence of P waves followed by a QRS complex. In lots of ECGs, even T waves may not be given, or even if they're given, they will be relatively bigger than the twitching that I'm showing. In fact, the highlight of atrial fibrillation, as you can see from the sketches, that the heart rate can touch normal, and then you can notice the acceleration. The main highlight of what I've at the moment sketched before you is the irregular RR interval. That's the peculiar thing that you will notice, that the heart rate was 200, then it changes to, let me say, 133, then it changes to 150, then it again upgrades to 200, and then can become normal also. So atrial fibrillation is one of the easiest ones to be picked up. In atrial flutter, you will always notice at least two abnormal waves before every narrow QRS complex, and these waves will neither be having characteristics of a P or a T. both height wise as well as duration wise. And apart from this, I also want to say that suppose you see two sawtooth waves, like at the moment I have hand drawn two sawtooth waves before every QRS complex. So that means that this is a 3:1 conduction. Don't answer it as 2:1, answer that as 3:1 conduction. Like suppose you see three sawtooth waves. He says what is the conduction? Answer is 4:1 conduction. Though explanation for this is given in MCQs as well as I have highlighted, because there are three non-conducted waves and one conducted wave per se. So if there are three, answer it as 4:1. If it is two, answer it as 3:1. And when it comes to atrial flutter, also because the macro reentrant circuit is present in the right side, so you will be able to see these waves primarily in lead number 2, 3 and AVF, because 2, 3 AVF are primarily going to study the right side of the heart. There is absolutely no reason why flutter can be ever confused with PSVT, because here you will be able to see only one abnormal looking wave before every narrow QRS complex. Along with that, a magnitude of ST segment depression has also been highlighted. I repeat once again, it would always be a good idea to actually note this information down by hand drawing with me while I'm doing this activity, because then you will be able to remember it relatively better. Because at the moment it might look easy to you, but then there's a tendency of forgetting also, no? So always when you hand draw anything or note down any information, you tend to retain it on a longer basis. When it comes to WPW in a patient, the moment the P wave will finish, you will notice there would be no Q wave. Then there will be a presence of a delta wave that will be easy to decipher because of change of the slope. The highlight is exactly when the P will finish, you will notice this upswing, change in the upswing rather, and a delta wave present. And along with that, obviously, family history is given. It's all the more welcome. In ventricular bigeminy, you will be noticing normal sinus rhythm. Then there's gonna be a broad QRS complex. Again, S node says, give me back the control. So normal sinus rhythm. You once again have a broad QRS complex. So this is happening alternatively. It's a normal sinus rhythm and then a broad QRS alternatively happening, and that is why we call it bigeminy. And if you do not treat this bigeminy, then this is what is going to happen. The ECG of this patient will start revealing a sinusoidal pattern and a broad QRS complex tachycardia, which is shown here. I have deliberately not shown the Josephson sign because I've already spoken about it, or the asymmetrical rabbit ear appearance, but the sinusoidal pattern is easily identifiable when it comes to a VT. And when it comes to Torsades de Pointes, then I'll just draw baseline rhythm, and once any electrolyte imbalance, hypokalemia, hypocalcemia, hypomagnesemia would start, you will notice that the sinusoidal pattern will be changing in amplitude. And therefore it's important, because don't mistake this with especially I would say electrical alternance, because in electrical alternance it will be a normal duration QRS whose voltage will be fluctuating, but here it is a broad QRS. I repeat once again, in electrical alternance, which is discussed in pericardial effusion topic and also in cardiac tamponade, you will notice normal duration QRS amplitude changing, but here it is broad QRS amplitude that is changing. And ventricular fibrillation is anyway one of the easiest ones to identify, and there would be a patient who would be pulseless, and for ventricular fibrillation per se there would be no drug of choice as well. Once you have hand drawn this activity, we will also put in the same discussion the drugs that will test your pharmacology and presence of mind as well. In atrial fibrillation, for rate control, I have explained to you that the drug that will be used will be esmolol/verapamil, and for rhythm control, it would be a class 3 antiarrhythmic by the name of ibutilide. The same answers for rate control and chemical cardioversion will be given even for cases of atrial flutter, but whenever you are answering for a patient of PSVT, always be careful. Is he asking about prevention? Is he asking about the treatment part? Since at the moment I'm focusing only on the drugs, I have already highlighted for AV and RT the best one is catheter ablation, but since this is a comparison of drugs, so it is for treatment that we use adenosine, and that also I've explained that first would be carotid sense massage to buy some time, that is so that at least the nurse can fill up adenosine in the syringe. It is verapamil which is to be given first, and adenosine also causes a transient bronchospasm. So whenever you push 6 mg shot of adenosine, you need to warn the patient that you will get a feeling as if you are suffocating, because already he's having palpitation. So you need to tell him that when the medicine will work, you will get a short limited, it's a time limited effect only. But because adenosine causes bronchospasm, telling the patient in advance will always help. When it comes to Wolff-Parkinson-White syndrome in a patient, the ideal answer for the MCQ will be procainamide, because most of the time he will ask you about an acute event. But if he says, how do you prevent these events from occurring again, that is palpitations and dizziness episodes and syncopal episodes, it is flecainide, though ideally we should go for radiofrequency ablation. But as I told you, I'm comparing the drugs part here, that's why it is important. Now, what is the treatment of ventricular bigeminy? So the drug of choice for the commonest arrhythmia seen with digoxin toxicity is lignocaine, and the same lignocaine has also been taught to you for ventricular tachycardia. But when the question says post MI ventricular tachycardia, it is lignocaine which is to be answered. However, let me say, if in case he is not mentioning regarding post MI and he says the word stable, then it is amiodarone which is to be used. And obviously, if it's a pulseless patient, then we will be going in for a non-synchronized DC shock. For torsades pointers, it is magnesium sulfate that will be used, also used in eclampsia and even in impending respiratory failure. But there is no drug of choice for ventricular fibrillation. Guys, I will rate this as one of the important slides that I want you to remember, and I would like you to actually note it down by yourself so that you can definitely perform relatively better as compared to competitors. And the more you will try to hand draw this kind of information, you will be able to pick up the abnormalities relatively better. I have already highlighted at this juncture regarding the following domains. So let's just make a summary here as well. And this summary will again help you realize the aspects with respect to QRS complex specifically. Abnormalities of the QRS complex is what I've highlighted. I have taught you regarding narrow QRS complex. This was PSVT as I highlighted. I've also taught you regarding situation causing a broad QRS complex. In fact, whenever we talk about QRS complex, you always have to be watch out for change in the slope in the upswing of the R wave, that is a delta. You have to also contrast this with what I draw next as J wave / Osborn wave. You see, I have already explained to you that the end of the S is what is technically called as the J point or the isoelectric point, but now I have drawn a J wave, and lastly I am highlighting at the same area but rather in a different way, a wave that is called as epsilon wave. Let's just quickly recall the important information here, guys. Whenever you are going to get a question on narrow QRS complex tachycardia, it is PSVT that must always be thought of. In fact, in lot of questions, he might write the word AV and RT. And I have today taught you that there is also an arrhythmia with respect to atrioventricular reentrant tachycardia. That was having two versions, no? The antegrade conduction and the retrograde, that is orthodromic conduction. I'll just take you back to the slide, which is the reason why I have written AVRT for narrow also, because AVRT will fit into both narrow complex and wide complex. If I go back in the diagram, this is what I had highlighted. If it is going to be antidromic conduction in Wolff-Parkinson-White syndrome, then it is going to be broad QRS. But if it is going to be ulta, that is orthodromic conduction, it's going to be narrow QRS. Let's just make up the entry of this point as well. The entry to be made here is that if it is going to be AVRT, atrioventricular reentrant tachycardia, then if it is a reverse ulta conduction orthodromic, it will be having a narrow QRS complex. Then is broad QRS complex tachycardia. Now for this, there are two possibilities which should be remembered. They will usually ask you about monomorphic ventricular tachycardia or about polymorphic variety. Delta wave in ECG versus EEG should never ever be confused. I've already sensitized you to that. If it is going to be delta wave in EEG, then it's going to be answered as NREM stage 3. This is a soldier who's posted at Siachen Glacier and is suffering from severe hypothermia. His PR interval is prolonged, his RR interval is increased because hypothermia causes bradycardia. In the diagram, you can notice regarding presence of J wave, which is also referred to as Osborn wave per se. This is going to be when the core temperature of the body is less than 35. You very well know 32 to 35 is moderate, 28 to 32 is moderate, and less than 28 is severe hypothermia, and gradual rewarming of the body would be required. In contrast, if you encounter at the same point, that is at the J point, two abnormality, and J point is a part of QRS complex only, no? Because end of S is the J point. So two abnormalities right at the end of the QRS complex are J wave and epsilon wave. Epsilon wave is with respect to arrhythmogenic right ventricular dysplasia. So you can see the pattern emerging here. I actually first talked about abnormalities of the P wave, then abnormalities of the PR interval, then I've talked about abnormalities of the QRS complex per se. And after this, I will now be teaching you regarding abnormalities varieties of the ST segment. And over and above this, I also want to remind you that when it comes to ventricular fibrillation, your main treatment for the person will be non-synchronized DC shock. The alternative term for non-synchronized DC shock would be written by you primarily as defibrillation. And if you read the algorithm for management of ventricular fibrillation, because it is a shockable rhythm, we are obviously giving DC shock, but in the literature you will also read about adrenaline. On this, the query of most of the doctors is that, sir, we are giving adrenaline to this person. Adrenaline is given when there's a cardiac arrest, when there's a flatline ECG. But in this case, why are you giving adrenaline? Because adrenaline is supposed to restart the heart. It is supposed to stimulate the SA node and get the cardiac activity back to normal in a asystole patient. In this case also, we are giving adrenaline. Why? So the reason for this would be to enhance the coronary perfusion. I would suggest you that after you have done with the ECG and the arrhythmias component, that is both lecture 1 and lecture 2, I would like you to then read about BLS, basic life support, and advanced cardiac life support as well. I repeat the fact once again, both BLS and ACLS, basic life support, advanced cardiac life support in emergency medicine section must be read by you so that you are able to comprehend the aspects relatively better, because ultimately ACLS is all about tachyarrhythmia management only, or specifically, if a person has become pulseless, you should know what is the approach to be followed. So I want to repeat once again, in cardiac arrest, when there's a flatline ECG, I give adrenaline to stimulate the SA node and restart the heart. But in this case, why am I giving adrenaline? Is mainly to increase the coronary perfusion. Please remember the fact, I want to enhance the blood supply, because after all, what is the cause for ventricular fibrillation? It is ischemia, no? Ventricular fibrillation is the commonest arrhythmia that occurs in MI and causes sudden cardiac death in the first hour. So if I provide more oxygen, I will be in a better position to terminate this arrhythmia. And yeah, a DC shock might have to be repeated in the person as well, but adrenaline in cardiac arrest and adrenaline in ventricular fibrillation are given for different reasons. I repeat once again, in cardiac arrest for stimulating the SA node, in this case for enhancing the coronary perfusion, reducing the hypoxia, so that at least you can get the rhythm back to normal. Ventricular tachycardia and ventricular fibrillation make the patient pulseless and chances of death are very, very high. So as soon as you put on the defibrillator, once you evaluate the rhythm, you can deliver a DC shock, which would be the non-synchronized variety, and terminate this process. Now we will talk about ST segment changes, highly important component. And I usually find that people are able to remember this. Why? Because of the mnemonic that I will say. Because the mnemonic I want you to remember is pretty straightforward. We're going to talk about ST elevation. The mnemonic is elevation AB. Now let's just expand this mnemonic, go into each and every point so that you are more comfortable in remembering this. The first and the foremost would be alphabet E, and that would be electrolyte imbalance. The electrolyte imbalance that I want you to remember here is hyperkalemia. Remember like this, because the word is hyper, therefore it means the arrow is going up. If the arrow is going up, that means T wave will also go up. So tau tinted T wave, and following the T will be ST segment. So remember, alphabet E here is electrolyte imbalance. We're talking about hyperkalemia, and the opposite of this, hypokalemia, will be having a ST depression. The next condition causing this would be alphabet L, left bundle branch block. There's a separate lecture on left bundle branch block as you scroll down subsequently, where this point has been highlighted. Now suppose there are 100 students or doctors sitting in a classroom. If I'm taking a face-to-face class, suppose there are 100 of you sitting, it's a possibility that maybe 1 or 2%, or maybe maybe a little more sometimes, might be having ST elevation without having any symptoms per se. I want to tell you that physiologically speaking also, in some populations you might be having ST elevation without any threat to life. This is early repolarization variant. That is, the next E has been taken care of. Now I want you to remember alphabet V and A. Alphabet V and A is to be remembered for ventricular aneurysm. This is a structural complication that is seen after myocardial infarction and predisposes to recurrent episodes of VT. I repeat once again, ventricular aneurysm seen after MI predisposes to development of recurrent episodes of ventricular tachycardia. So implantable cardioverter defibrillator is recommended for the patient. We come to alphabet T now of this mnemonic, that is trauma. And by trauma, I don't mean at the moment a punch to the chest, or I would say elbow to the chest, or like in case of a MMA fight. What I am talking about here is trauma caused by catheter, which you are using to do pericardiocentesis procedure. The moment the catheter will touch the surface of the heart, you will notice a gross ST elevation coming up. That's because of irritation of the pericardium. Alphabet I is the easiest one for anyone of us to comprehend, that is ischemia, and that is myocardial infarction I'm talking about. I've already highlighted that the ST elevation of MI is going to be convex upward, so the term used are either Pardee sign, or sometimes he might just use the word tombstone pattern as well. It will be convex in a upward direction. Now we come to alphabet N, that would be of elevation. I'm finishing the word elevation at the moment, and this is important not to be forgotten. This is non-occlusive vasospasm. Now I hope you recall, non-occlusive vasospasm is gonna be prinzmetal angina, and when I've described prinzmetal angina, I have said the only angina having ST elevation is prinzmetal angina. Please remember, non-occlusive vasospasm word was written just because prinzmetal angina was not being able to fit into the mnemonic. So yeah, I mean, I've used an alternative terminology here. Now we look at alphabet A and B, the remaining ones. Alphabet A would stand for acute pericarditis. When you studied about the diseases of the outside of the heart, I've talked about phrenic nerve being responsible for conduction of this chest pain to the shoulder of the person, especially the left shoulder, and acute pericarditis can have ST elevation, which is concave in upward direction. I repeat once again, in MI it is gonna be convex upwards, whereas in acute pericarditis it will be global. All the leads will be having ST elevation except AVR, because AVR anyway reads the heart the other way around. I've already sensitized you to the fact that AVR, the first wave, the ECG, the P wave and the T wave will be always coming upside down. And alphabet B here would stand for Brugada syndrome. This is a sodium channel defect. It is per se a SCN5A defect, which it will be having genetic basis, and in these patients the ST segment elevation present will be either having what we call as a cove pattern or can be having a saddleback pattern. Again, I have taken a separate lecture on the topic of Brugada syndrome also, so do remember that aspects which I am now highlighting before you. So the mnemonic elevation AB is of paramount importance for one of the abnormalities of the ST segment, and obviously along with the retrospective history given in the question, you will be able to decipher any one of these. I repeat this once again: elevation, electrolyte imbalance, left bundle branch block. Try to remember here only while you're listening to me. VA would stand for ventricular aneurysm. The second E is inconsequential physiological, so you can neglect that. Trauma, then ischemia, then is Osborne wave. In fact, alphabet O, I want you to remember at the moment that I'm now incorporating in this discussion is alternative name for J wave. I have deliberately mentioned this term now to incorporate the TION part of the mnemonic. Osborne wave is simply alternative term for J wave, which is encountered in patients of hypothermia. So from hypothermia as a alphabet O, you can remember this. And I can just go back to my previous slide also, where I was mentioning regarding J wave. I can say that I have mentioned the Osborne wave already. Then is non-occlusive vasospasm. That would be an important component of the discussion. Prinzmetal angina, which can be treated with nitrates and prevented with calcium channel blockers. Along with that, A is acute pericarditis, B is Brugada syndrome. I hope you have been able to remember it. Now I'm going to teach you conditions which will be having a ST segment depression. Some of the things you just need to rather use English, and you can definitely be easily able to comprehend them even in the exam. Instead of hyperkalemia, just use the word hypokalemia. The findings of hypokalemia, three important ones are: one is prominent U wave, another one is gonna be T wave inversion, and because T is going down, the ST segment can definitely go down as well. Apart from this, I'm describing a person of chronic stable angina. Like this particular gentleman, he says that he was walking fast while he was going towards his car in the parking lot. Like this particular guy, he is in rush for some meeting or he's late for some family function. So because this person was walking fast, that is when the chest pain came. Please remember, chest pain in this guy is not at rest but on walking fast. You are aware from the discussion of especially coronary artery disease that if a person is having minimum 70% blockage in any one of the coronary arteries, whenever the person will walk fast, run fast, walk on treadmill, or like you can take example of our former dashing captain Saurabh Ganguly sir. Saurabh Ganguly suffered from episode of chest pain on exercise while he was working on the treadmill. And to be a cricket captain of Indian team, you have to be ultra fit. But considering the heart disease prevalence in our country, Saurabh Ganguly was found to have multiple blockages in a single artery, so had to undergo angioplasty or stenting of the coronary artery per se. But then whenever you read about this kind of a description, chronic stable angina, it will always be having a ST segment depression, and the first test that you do in these patients is treadmill test, and in treadmill test, yeah, you will be able to demonstrate the changes. Then the next aspect which is to be remembered would be a guy who's gone to, let me say, a rave party. And in this rave party, snorting cocaine, like lots of time, you will have these so-called call center employees, or I would not like to say only call center employees, young people, very dashing people, very intelligent people, thinking that it is cool to take drugs. And nowadays everybody knows about HIV/AIDS, so they don't do needle sharing. They will be snorting cocaine, and cocaine overdosage can contribute to severe vasoconstriction, reduce myocardial ischemia, or contribute to myocardial ischemia so bad that some people might even have a MI. So those rape party deaths that you read, that a 20-year-old guy, healthy, previously healthy, muscular chap, works out in a gym, and I mean nobody knew that he was doing drugs. And this guy, he snorted cocaine. The cocaine overdosage can contribute to even a myocardial ischemia, and in minute dosages, obviously lesser dosages, can cause ST segment depression. The fourth entry I want you to remember here is digoxin. Now mark my words there, I'm not saying digoxin toxicity. Digoxin toxicity will cause ventricular bigeminy, which I mentioned in the previous lecture. At the moment, all I'm talking about is digoxin per se. When I say digoxin, it will be causing a vagus nerve stimulation, and as a result of it, the heart rate of the person will decrease. So one of the physiological aspects of digoxin administration is PR prolongation. Digoxin administration also causes a ST depression. So if somebody is on digoxin and is walking on treadmill, you will not come to know that whether the ST depression is due to blockages in the artery or is it due to digoxin per se. So anybody who is on digoxin should not be walking on a treadmill, because digoxin itself causes ST depression. And in fact, this ST depression is very characteristic. I'll just try to hand draw this before you. This ST segment depression that I have highlighted is referred to as a hockey stick sign. That is itself an MCQ, no? Hockey stick sign with respect to ECG is with respect to digoxin administration. So I want you to remember this peculiar terminology, because in CNS also I will be talking about hockey stick sign, and in fact hockey stick sign can be present even on echocardiography. In echocardiography is mitral stenosis. In ECG is the topic that we are studying, and when it comes to CNS, if you have gone through the CNS component, I'm not writing the CNS component at the moment because I don't want to go overboard. I'm just saying verbally, prion disease, variant Creutzfeldt-Jakob disease. So on MRI head you will hear me talking about hockey stick sign with respect to variant Creutzfeldt-Jakob disease. That's a prion disease, but let's focus on the cardiac aspects at the moment. And the third aspect is digoxin also causes a QT shortening. In fact, these three are physiological effects, and how to remember that? Just remember, arrow for PR will go up and the arrows for both of them will be on the lower side. That is ST depression versus a QT shortening per se. These are findings with respect to ST segment depression that you need to remember the etiology. And for digoxin toxicity, I would like to refresh your memory in case you don't remember it from pharmacology or congestive heart failure topic per se in the app. Let's just practice this at the moment. Digoxin toxicity. There are two arrhythmias which are always described. One is non-paroxysmal atrial tachycardia with a variable AV block. I repeat once again, it would be a non-paroxysmal atrial tachycardia with a variable AV block, and second you will always read will be VB, that is ventricular bigeminy, which can deteriorate into ventricular tachycardia. If he says in the MCQ which of the two arrhythmias is more common, the answer is ventricular bigeminy. If he says which of the following arrhythmias is most characteristic of digoxin toxicity, then your answer would be given as non-paroxysmal atrial tachycardia with AV block. Both of these aspects are valid for the toxicity component. How do you handle digoxin toxicity? Well, you can be using digiband, right? So please read the question very carefully, because you are using FAB antibodies for toxicity. But if he says how do you treat the bigeminy component, then the drug of choice for ventricular bigeminy is lignocaine, and untreated ventricular bigeminy, NSR, premature ventricular contraction, NSR, premature ventricular contraction, alternatively will change into only premature ventricular contraction, PVC, 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 PVC again and again. And if ventricles beat faster without getting filled with blood, we call it ventricular tachycardia. So causes of ST segment elevation and depression are less likely to be forgotten. One, because of the usage of this mnemonic. Again, try to hand note it down by yourself, though it's given in the notes, and compare that with causes of ST segment depression. In fact, most guys, they do very well with ST elevation and ST depression because it's very fascinating. So I usually have not had any problems with people having problems with understanding or remember these aspects. The next part that we will discuss is about T-wave abnormalities. We will first talk about the normal height of the T-wave when it comes to the limb leads or the chest leads per se. Please remember the height is less than 5 millimeter when it comes to limb leads. I've written LL, and if the vertical height is less than 10 millimeter, that would be for chest leads. So why are we studying this? Is because if the height is more than this, then we can call it either a hyperacute or a tall tented T wave. Now I'm going to hand draw before you what I mean by the word hyperacute T wave versus a tall tented T wave, and I would like you to at the moment listen to what I say very carefully and notice the subtle differences that I say also. You see, in the first sketch, what I'm going to do is I will increase the height of the T wave definitely, but you will notice that one, it has been made relatively less broader, and the vertical height is even less than the height of the R wave per se. The topmost part is not very pointed, it is relatively rounded, but in the second one, I'm drawing the height of the T wave much more than even the height of the R wave, and the top part of that is pointed. So there's a fundamental difference between the two. The first one that I've highlighted is called as hyperacute T wave that is encountered in myocardial infarction. In fact, if they ask you what is the earliest ECG finding in MI, don't answer ST elevation, because ST elevation may not occur in MI. No, there are two types of MI, ST and non-ST elevation MI. The earliest ECG finding is hyperacute T wave. The uppermost part of this will be relatively rounded, and at the same time it will never achieve the height of the R wave. Whereas when it comes to what I've just highlighted, that is tall tented T wave, then this indicates that the person is having a hyperkalemia. Apart from this, there can also be a possibility that they can ask you regarding a T wave inversion per se. Now let's understand where will we be getting a T wave inversion. The first time I've highlighted a T wave inversion is with respect to hypokalemia. The logic is that whenever potassium will become less, because arrow is going down, so T wave will also be going down and ST depression will also be present. In fact, it can also be found in MI. Which variety of MI will be having this? Both ST as well as non-ST elevation MI can be having a T wave inversion. Even subarachnoid hemorrhage. Now this can itself be asked as a question, that which of the following is a ECG finding of stroke. When you read this for the first time, that ECG finding of stroke is asked, or per se was asked in the previous years, a lot of students said, sir, I thought the question is wrong. Because you see, whenever we are reading about ECG findings, we are always thinking in terms of cardiac issues, but he deliberately asked ECG finding per se with respect to stroke, that is cerebrovascular accident, it can be T wave inversion. That's a very peculiar statement that I made, guys. ECG findings of stroke are, then the answer would be in subarachnoid hemorrhage, you can have a T wave inversion. That's due to catecholamine excess that occurs in excruciating pain associated with subarachnoid hemorrhage. Then T wave inversion can also be seen with S1Q3 T3. Meaning of the word S1Q3 T3 would be deep S waves in lead 1, then would be deep Q waves in lead 3, and then T wave inversion in lead 3. And this is going to be encountered in pulmonary embolism. The big clot in the pulmonary artery, it could either be a saddle embolus or it could be blocking one of the branches of the pulmonary artery. So therefore the right ventricle will fail. Whenever you read about right ventricular failure due to non-cardiogenic causes, like the clot came from the legs, person was having deep vein thrombosis, the clot from the soleal vein migrated up towards the IVC, then towards the heart, and then went into the pulmonary artery, either the main branch or was a saddle embolus, and cut off the blood supply to the lungs, causing pulmonary infarction. That's going to be acute pulmonale, and because of the physical blockage caused by the clot, the pressure of the pulmonary artery will rise, pressure of the right ventricle will increase, and when the right ventricle will be grossly dilated, that's when the person would be having a T wave inversion coming up. So there are three T wave abnormalities that I want you to remember: hyperacute T, tall tented T, and a T wave inversion. And then the next part of our discussion will be with respect to the QT interval. And while I'm writing it, I straight wanna say that QT interval will always exhibit an inverse relation with calcium and magnesium. That's one of the important aspects that is usually asked in the exam with respect to QT. And what is the normal QT interval? Then I have already explained right in the starting of the discussion in ECG and Arrhythmias part 1 that normal QT interval will be 9 to 11 small squares. QT interval will be starting from the starting of the Q to the end of the T wave. This entire duration is called as QT. In contrast with what I've highlighted at the moment, that is the end of the S and the starting of the T wave, that is the ST segment. The words are starting and end and starting. That final difference has to be kept in mind. Normal duration of QT interval is 360 to 440 milliseconds. So since one small square is 40 milliseconds, I said it is a range of 9 to 11 small squares. Anything less than 9, we'll call it a short QT. If it's more than 11 for 40, we'll call it a prolonged QT. And one of the important causes of especially QT prolongation that they love to ask you is with respect to tetany. This person can die because of laryngospasm, and he can give you a clinical scenario for tetany of a post thyroid surgery patient, because you know that after thyroid surgery there's a possibility that there might be inadvertent parathyroid resection also. So once the PTH values will fall, calcium will also fall. In almost all MCQs or tetany, because he will always talk about findings like Chvostek sign, Trossius sign, etc. He knows that you can solve them, so he will love to incorporate this ECG aspect. And the opposite, what I can say is, I can say my patient is suffering from squamous cell cancer of the lung. You are aware of the fact that squamous cell cancer of the lung can produce PTH related peptide. It's not true PTH, it looks like PTH, so it will stimulate the gland causing more PTH, and therefore and the end result would be development of hypercalcemic crisis, and therefore QT shortening will occur in the person. In fact, for hypercalcemic crisis, he can talk about malignancies, which are one of the important cause. I mentioned two of them, breast cancer and lung cancer. Whenever we talk about lung cancer, the first thing that comes to our mind from paraneoplastic perspective is oat cell cancer, because oat cell cancer is capable of causing SIADH, syndrome of inappropriate ADH secretion. It is capable of contributing to Cushing syndrome due to more ACTH per se. But when it comes to squamous cell cancer of the lung, it can contribute to production of PTHRP, parathormone related peptide, and this PTHRP per se can increase the calcium values. Another cause of hypercalcemic crisis can be a parathyroid adenoma. There are 4 parathyroid glands, so the tumor can be originating in any one of them, and usually is more common in the inferior ones. The third important cause for hypercalcemic crisis would be having non-caseating granulomas. The condition I'm talking about is sarcoidosis, where these granulomas can be synthesizing vitamin D3. The next person is actually a gym freak. He has joined a gym, and his coach, who's not a technical person, has told him that we will be giving you some health supplements and you need to pay extra for that. Now, because everybody wants to look good nowadays in a very short time frame, this guy is taking these illegal or wrong kind of zinc supplements that could be containing not only steroids but could be containing excess of vitamins also. That is, excess of vitamin D3 in a gym freak can contribute to again hypercalcemic crisis. And why we are worried about hypercalcemic crisis is because of the cardiac issue. I mean, why am I discussing about this endocrine topic at the moment is because hypercalcemic crisis can contribute to systolic arrest of the heart. Like I said, tetany can kill a man due to laryngospasm. It is systolic arrest which is of danger with respect to hypercalcemic crisis, and therefore I would like to do a quick workup of this person so that I can at least identify that this person can expire and I can take corrective steps also. So I will obviously be getting the serum calcium of the patient done, but because even if I draw the sample right now and send it to the laboratory, even if you're working in, let me say, Apollo or Max or any other hospital, turnaround time will be at least half an hour, 1 hour. I mean, if I draw a sample of somebody whom I suspect is having more calcium, the report might come after 1 hour, and that might be too late from the perspective of systolic arrest. So if I'm gonna be suspecting hypercalcemia in a patient, I will be doing a bedside ECG that will be showing a QT shortening in the person, and meanwhile obviously the report of calcium will also come. And it is always advisable to actually check the values of serum calcium as well as serum albumin, because you are aware that per se calcium can be in the bound form and as well as in the ionized form. So when the report will come in this particular chap, serum calcium can be more, ionized calcium will be more, and serum albumin will be normal anyway. Serum albumin normalcy must always be demonstrated in whenever there is going to be derangement in the form of either more calcium or less calcium in the body. Now is the time of treatment of this patient. So first line management will be hydration. So I will be giving normal saline to the patient. To this bottle of normal saline, listen to the words carefully. You will be to the bottle of normal saline adding furosemide, which will go in the form of a drip to the patient. Why? Because furosemide mechanism of action will be that it will cause calcium loss in the urine. In fact, that is an important aspect that you need to remember. Furosemide is always to be given in the form of a drip. Now, because your nurse is usually used to you writing bolus shot of furosemide 20 or 40 milligram for pulmonary edema, so she might give it bolus. If you will cause a bolus furosemide, it might be actually lethal to the person, because bolus will cause diuresis, and the moment the diuresis will occur, what will happen to calcium values? They will spike even further. Normal calcium values are 9 to 11. If they go up to 13, 14, going up to 15, if you cause diuresis, the calcium values will dramatically increase. They're already increased, no? So they can be systolic arrest of the heart. So this point has been asked a couple of times, that furosemide for management of hypercalcemia is given in the form of a drip and not in the form of a bolus. The drug of choice for this condition would be bisphosphonates. We are very familiar with usage of risedronate, which is given once a week to women who are having osteoporosis. But at the moment I'm talking about ibandronate. When this ibandronate would be given intravenously, this will cause calcium to go into the bone. See, it is more in the blood. Like, that is why it is dangerous, because it can cause the heart to stop. So I can send it into the bones. So bisphosphonates can definitely be used. And along with this, though there are multiple bisphosphonates available in the market at the moment, I can supplement the action of this with calcitonin nasal spray. See, calcitonin is the antagonist of PTH. So when calcium or calcitonin per se will send calcium into the bone again. The advantage will be calcitonin sending calcium in the bone. It will strengthen the bone in osteoporosis. In this case of mine, it will just help in reducing the overall calcium values and prevent a systolic arrest in this particular chap. So I definitely want you to remember the importance of ECG per se for both hyper as well as hypocalcemia. So QT shortening and QT prolongation aspect should be remembered. And I've already sensitized you to the fact that whenever he says the word prolonged QTC, that is when you need to always think in terms of Torsades de Pointes. And now I come towards the end of what are you supposed to do whenever you see a ECG based question. My first advice is, do not try to do all ECG based questions in 1 or 2 days or maybe 3 days. Spread them out. Do maximum 5 to 10 questions of ECG based and then switch on to another topic, maybe from cardiology, maybe move on to neuro, or maybe do another subject. But try to see ECG daily, because daily in the morning when you will start seeing ECG and you start analyzing those waves, your eyes will gradually, the word is gradually, pick up the subtle changes. One of the important things that you need to do is, in the first 5 seconds, try to evaluate the heart rate. Where will you look for evaluation of heart rate? Always look in lead 2, which is given right at the bottom. And you always need to calculate the large squares. In this case, if it's going to be less than 3 large squares or more than 5 large squares, you will be able to decipher whether there's a tachycardia or whether there's going to be bradycardia in the person, because that obviously has a diagnostic importance. Heart rate is always inversely related to RR. Interval is always to be kept in mind. PR interval is always inversely related to heart rate. In fact, everything that I've described for ECG will be having an inverse relation. Then calculate the axis the way I have explained to you, that is with respect to lead 1 and lead number AVF. And the advantage is that axis deviation will tell you problem is in which side of the heart, especially with respect to chamber enlargements per se. Then check for abnormalities of the P wave. There are 2 abnormalities of the P wave that I've explained to you, apart from P wave being absent. P pulmonale, then I've spoken about P mitral. I've also talked about pseudo P pulmonale, but the point is always check for abnormalities of the P wave with respect to the duration, with respect to the height, and also check whether it is followed by FB here, means followed by QRS complex, because that signifies a normal sinus rhythm occurring in a person, and absent P waves will be present in atrial fibrillation, sick sinus syndrome, and even in hyperkalemia. If the P wave is fine, then check for the PR interval per se. There can be 2 possibilities. Either the PR can be short. Each of these steps will be taking approximately 5 seconds. Conditions causing a short PR interval are Lown-Ganong-Levine syndrome and Wolff-Parkinson-White or rheumatic fever per se, the minor criteria. But when it comes to, the wide, that's where I'm talking about the rheumatic fever. Prolonged PR interval is one of the important diagnostic criteria. Ashkoff nodules will slow down the conduction. So whenever you read about per se first degree heart block, the word is heart block, but do remember, not in Moubitz 2 heart block. I want to repeat this once again. First degree heart block, Moubitz 1, complete heart block, they all will be having a prolonged PR interval, but not Moubitz 2, because in Moubitz 2 the PR interval usually remains constant. I've already explained to you the concept of dropped beats, that whenever you want to look for a dropped beat per se or encounter a dropped beat that is a P not followed by QRS, look at the PR interval before and after. If it is going to be unequal, it is Moubitz 1. If it is equal, it is Moubitz 2. I want to repeat this fact once again, guys. When it comes to PR interval, it is normal in Moubitz 2 heart block. So I've written the generic term heart block, but this does not include Moubitz 2. Or let me just write it here also, so that you remember the aspect. Except Moubitz 2 heart block, because in Moubitz 2 heart block, as I explained to you, the damage is bundle of phase that is below where the PR interval electrically is present. Now suppose in the exam you have already spent 20 seconds in the ECG, heart rate is normal, axis normal, P wave and PR interval are normal, then there could be abnormalities with respect to the QRS. I have already explained to you regarding differentials for narrow complex QRS tachycardia. That's gonna be always a supraventricular tachycardia in the form of atrial fibrillation, atrial flutter, or PSVT or AV and RT. But when it comes to a wide complex QRS tachycardia, it would be limited options with respect to either a ventricular tachycardia or a torsades de pointes. Now, once you're done with this, you will check out, like suppose if they're normal, you will always check out the J point for J wave or Osborn wave, if hypothermia is given in the question, that is, and then you will check for whether there's a ST segment depression or elevation in all the leads. You need to scan through all the limb leads, all through the chest leads for elevation versus depression. The mnemonic has already been talked about, so there is no point of me repeating that mnemonic per se. Do practice it by yourself. I can assure you the fact that if 5 seconds are invested into each of these steps, 6 into 5 would be 30 seconds, and at the end of 30 seconds, suppose at the moment there is no conclusion from your side, then probably this question is on electrolyte imbalance, because QT interval then might be actually have to be counted by you, because QT interval always shows an inverse relation with respect to especially calcium and magnesium. So lots of time questions on electrolyte imbalances might also be present. Just try to implement this. Whenever you see a ECG based question in the app, first read the explanation. In the first read, don't try to solve the question, because your eyes will not be able to pick up the subtle aspects. I have rather put markings in the explanation. I have put markings for every abnormality that is detected. So in the first reading for ECG based questions, my request is don't try to analyze them or don't try to solve them. Because once they start going serially wrong, like 3 questions went wrong, 5 questions you go wrong, you will lose interest and you will dump it on the side, and all your hard work will go waste of listening to this discussion. Just listen to or read those explanations that I have given after each ECG based question with markings. I'm anyway there to access you. You can directly send me an email at my email ID marvamedicine@gmail.com in case you're not able to get a question across. But at the same time, whenever you are doing that question the second time, whenever you're doing a ECG based question the second time, first time read explanation, whatever I have said. Second time, try to deploy this. Look at the ECG, give it a time. Don't follow or don't try to go by the timer. Just remove the timer and try to just write down these steps by yourself. And once you do this activity 2 times, I assure you the fact, guys, those technicians and nurses who have been working in ICU for a long period now, they are able to pick up arrhythmias. They're very, very easy. We all doctors have a phobia of this ECG and mathematics, especially that whenever you look at that printout of a ECG, our hands and feet go cold. Especially it used to happen with me in my UG that yaar ye to hoga hi nahi. Correct. But then I realized gradually कि कैसे नहीं होगा. But when I started analyzing, or when I used to see a nurse with the 5-year experience of being able to analyze, I thought, I took it on myself, भाई मुझे भी आना चाहिए, right? So it comes with practice, guys. Because होता क्या है कि जब when you see the same thing again and again and again, then you get used to it. When you see something very occasional, very, I would say, scarcely, or like maybe in once in a month you're seeing 1 ECG, you won't make any sense of it. When you start seeing 5 every day, तो कुछ तो यार उसमें समझ में आना शुरू होगा ना धीरे धीरे इंटरप्रिटेशन स्किल्स में. So my humble request to you guys is please try to deploy it in the second read, and in the first read just try to follow the explanations that are given. And deliberately some of the questions are made difficult in the app. I agree to that, because we don't want you to party immediately. Now, if I give same thing, if you are able to solve a question immediately after listening to a lecture, then you won't study hard, right? It's after all a competition. So these are the aspects that I want you to remember for this particular topic. Thank you for your patience and hearing me out, and keep hammering, guys. All of you brilliant people, you can do it, man. It's just that attitude that is required, in a sense that you just need to keep working on a daily basis. New topics every day. Gradually your knowledge base will increase. That's what is required. Thank you.